The first topic is chemical injuries management protocols by Dr. Sunandini Bose.
Very good morning, everybody. I'm Dr. Sunandini Bose, and I would be speaking about managing the chemical injury cases, and I would be focusing mainly about the acute chemical injury. So we know that it can be caused because of alkali, acid, and even neutral agents. And in the last decade, because of the acid increased sales, so we see now a lot of cases in urban population as well as rural population. A lot of cases are for acid injury. So it is a very common form of ocular trauma that is happening in rural areas as well as urban areas. So coming to the positive agents, we know that it can be because of alkali and acid, and these products are very readily available in our household items also, such as lime or refrigerant, coolants, etc. So the severity of chemical injury depends upon the toxicity and the concentration of the chemical, the duration of contact with the chemical, the depth of penetration, the area of involvement or the limbal involvement, and the additional force and heat, etc. So before we learn to how to manage the chemical injuries, we need to grade them. So these are the widely classification that are used, that is the Roper Hall and the Dewars classification. Nowadays we use the Dewars classification more, which is based on the limbal ischemia and the conjunctival involvement. These are just a few cases where I'm just trying to show you that how you can grade these cases. So the parameters that need to be addressed are, you need to take a thorough history of the chemical. We need to know that what exactly has caused it. The first line of treatment is to do the inflammation control. So the primary goal is to reepithelize basically the ocular surface. And also you need to take the help of a general physician if you know that the patient has ingested or inhaled some toxic fumes. So the initial assessment starts from the eyelids, where you see the extent of blink and the extent of injury. For the ocular surface epithelium, you see the fluorescent staining, and everyday examination is must in these cases. So in the pictures, what I am trying to just show you is, in the first picture, if you see here, so you can see that the clear areas of limbal ischemia are is very distinctively seen. But in the second two pictures, you cannot see the limbal ischemia very nicely. That is because of the conjunctival hemorrhages that is masking the limbal ischemia. So most of these cases will have the limbal ischemia underneath the conjunctival hemorrhages. Also, please do not forget to take the IOP of the patient. Lot of times we forget to take it, and the patient lands up into a very bad glaucoma, and then it is very difficult to manage these cases. So the acute stage management starts with removal of the injurious agent, the assessment of the patient, control of the inflammation, and felicitation of the healing process, and that starts with the first line of treatment, that is the thorough irrigation. You need to do an irrigation for 30 minutes with 500 ml of balancer solution or any neutral agent, sterile neutral agent. Do put a topical anesthetic drug, and while you are doing the irrigation, make sure that the other eye is not getting a accidental chemical injury by flowing the water in that eye. So the type of irrigation fluid, I had already explained that it can be any sterile neutral agent, ringer lactate, balancer solution, and hyphoterin, which comes in a kit also nowadays, are very helpful. And you need to do a swab test so that the furnaces become clear and the slim blepharon does not form, and any issue that is having the particulate, you have to excise it. So the first line of treatment is over. Now we come to the medical management, that is the use of topical steroids. This is a main line of treatment. I'll show you in some of my cases that how a DEXA and a prednisolone will help in reducing the inflammation and further damage. Use a topical antibiotic so that a superadded infection is not there. Cycloplegics to relieve the pain. Anti-glaucoma if you're suspecting it is a high IOP. And lubricating eye drops for decreasing the mechanical rubbing and lubrication. Then in the later grades, if you feel that the epithelium is not healing, you can always use the oral therapy in the form of ascorbic acids and tetracycline. The most common drug that I use is a doxycycline 100 milligram BD, not in very young age group or a very old patients. And you can also use topical therapies in the form of N-acetylcysteine or reconstituted ascorbate also. So coming to the surgical management, tenoplasty or AMG, both tenoplasty and AMG, they are the first line of treatment in a surgical treatment. So what we generally do in this is you do the conjunctival peritomy and divide the tenous with the conjunctiva and advance the tenous onto the limbus, and you can just see in the last picture with this study that was published, you can see that the epithelium is getting healed in these cases. The next line of treatment is doing an AMG. So it has two benefits, that is a physical and biological. Physically, how to reduce the eyelid friction, and biological because it reduces the inflammation, it prevents scarring, it promotes the epithelial growth, and it prevents also the neovascularization. Procura is a prototype. It is a little expensive. You can have your own devices also that you can make. So this is one case study that was done for a sutureless contact lens type amniotic membrane. So I have used this kind of thing. So what you exactly do is you take the horizontal and vertical diameter and you fashion the AMG in your OT, and you put it in the contact lens. Take the contact lens, if the patient is in ICU and you cannot do the patient in the OR, you can just put it, in the bedside of the patient. So it helps with the patient if you are unable to do these cases. So these were some cases of the study has shown in infective keratitis. So this is one of my cases which was a grade 6 chemical injury. The patient was in ICU. I did not follow this method, but I just did Hakin method for an AMG on the bedside. So this is a healing process. Now what I want to show in this is you have to understand that after the healing also the patient will need a lot of other care also, and the patient might need many more setups of AMG. So the early stage of managements are the topical steroid, lubricants. In grade 3 to 4 as called the oral therapy, and in grade 5 to 6 the surgical therapies. So these are just some of my cases where I have done the treatment, and you can see that just with a prompt treatment you can have the next day patient is and the epithelial defects are healing. This is another case. You can see after the next day with the same treatment line, you can see that the epithelium defect have reduced widely. This is another case where it was a battery acid that was going inside the eye. You can see in 3 days with the same treatment, irrigation and topical steroids, the patient healed very nicely after 1 month. And this is the other eye where you have to use a BCL if the patient had a lamellar injury also. So the late stage management is a multidisciplinary action. You have to take care of the eyelid, you have to take care of the dry eye diseases, limbus tunnel deficiency, slim brephron, high IOPs. So this is one patient where I had done a simple excision of the granuloma and the slim blepharon and just did a AMG. The patient was not ready for a slit, and this is the 1 month picture. And slit, we all know that it is a late stage thing. So to summarize, we need a prompt eye washing and irrigation. Steroids are a must. You have to monitor the patient daily and do not be afraid to do a tenoplasty or AMG. Thank you.
Thank you, Dr. Sunandini. Thank you very much. Anybody wants to ask any question?
So ma'am, generally what, I practice in a multi-speciality setup. They are my own setup. So I see a lot of patients who have, inhaled these toxic fumes, and the patient is having burns all over the body. So that time you cannot take the patient to the OR because the patient is not hemodynamically stable. So the first line is just to, if you have started the therapy, the medical therapy, and you feel that the patient is still not, ready to go to the OR, you can just put it as a first line thing. And as I said that, most of the patient, if the initial therapy has not started within 24 hours, they will need at least 2 settings of AMG. Because the first setting of AMG, we tell the patient that this is just for the stabilization. Some area is going to heal, but the vascularization is going to go up because the first 24 hours, the steroids and the irrigation has not happened. So the inflammation has actually set in. So that is why you have to do the irrigation and start the steroid. And this is just the first line. And then you can always tell the patient that you will need another AMG or a slit later on.
Thank you, madam.
Yes, they will. So ma'am, generally these patients are lying on the bed. They are not much movable. And in the first 7 days, if I feel that the BCL has come out and the surface has not healed, I will do an AMG after that 7 or 10 days again. when I'm putting the BCL in the patient, I tell them that this might come out, but this is just a temporary thing because we cannot take you to the OR, and we might have to repeat the surgery after 10-15 days if this is not working.
Thank you, madam. Thank
you
you.
so much, sir.